very much for the kind invitation. It's a pleasure being here. It's always nice to see that something that starts with one email then ends up finally meeting the people. So thank you very much that we made this. You made this possible. Thank you very much for Professor Anjali and Professor Vinatama. Thank you. It's great for having us here. So maybe just for my journey, how it started and why I'm standing here, I guess for me and also for Eike. There's somebody who's very infectious in our department. He has left the department and he was standing here a few minutes before. So this is how the journey started, maybe 11 or 12 years by now. So this is how I got involved in the field, thanks to Jürgen Beck. I think a lot of you are neuroradiologists, and Jürgen was already elucidating this. In a sense, not to overestimate ourselves, but we are a key component of the equation here. As a neuroradiologist, you are going to be the driver for patients who are going to be the SIH patients. Why is that? This is exactly the same, because the clinical features and the opening pressure are very unreliable. So it becomes less and less clear as the patients come delayed. So the imaging signs are the ones that are the most important ones, and that's why neuroradiologists are very, very important in the entire equation. I will not go through the symptoms or most of these. As Jürgen said, this was the orthostatic, but this is something that disappears. There's things as we go on that we learn why patients are having certain symptoms, and I'm still very fascinated why things are happening. For example, a lot of these patients will refer to audiovestibular symptoms. And why is that? Maybe this is a venous compression, but if you go back, and I did do that myself, to go back at your anatomy books, there is actually a connection between the CSF compartment and the perilymph. So it is very possible that the audiovestibular symptoms in these patients are due to the fact that the pressure that's in the CSF has an influence on the perilymph, and this, on the contrary, also influences the endolymph. So just to give you some thoughts, there are also things that we are just learning as we go step by step, why potentially some symptoms in these patients do occur. I will skip that. So a variety of symptoms, we really need to pay attention, because a lot of these imaging signs and the clinical findings are there, but you need to be the Sherlock Holmes who's looking for them. As being said, it's not a rare disease. In Thailand, I think you have around 70 million people, so you should be seeing around 3,500 to 4,000 patients a year. So this is at least a number that is according to the big books that should be there, but probably it's even a lot more than 4,000 patients a year. Why is everything happening? I will talk about brain imaging, but maybe just to give you the backstory. So we have a CSF production and we have a CSF resorption. That's physiology. And this gives us a certain CSF volume. In these patients, we have a leak. So the entire system is off balance clinically, demonstrating certain clinical findings, and also imaging-wise. So what do we have? We have a closed compartment within the brain, within the skull. So we have the brain parenchyma, what we see here. And we have the blood compartment and the CSF compartment. The CSF compartment shrinks and becomes smaller and needs to be replaced by something, because the volume within the skull is always given. It's constant. It cannot change. So something needs to increase. And the only thing that can increase is blood. So all the things that we are usually seeing is increased blood volume. And this is it. There are different leak types. We will always go through it a little bit, because it has a certain influence on diagnostic and also on therapy. But I think it's important to kind of have them memorized. And sometimes finding those leaks is very, very challenging. The first ones, the ventral leaks, you as radiologist, you have seen those spurs for the last 10, 15, 20, 40 years, how long you're reporting CTs and MRIs. And you have never reported, or a lot of times you don't report them. Why? Because they usually don't cause any problems. And probably several of us sitting here also have these spurs, but they are not causing trouble. But in patients with SIH, those are the ones that are causing trouble. And those are the ones we need to really zoom up and mag, because otherwise we will not see them. Only very, very occasionally, this is probably the largest one I have ever seen, but this is not the standard case. This is one of the largest spurs that I've ever seen. Usually there are 1.5 millimeters large, and you really have trouble seeing that. The lateral tears, there are certain imaging features which Eike will go through, how you can diagnose them, how you can find them. Last but not least, I will talk about this in a second talk. This is a new pathology, something that we have, or Wouter achieving, discovered around 12 years ago. It's a direct connection between the intrathecal compartment, between the CSF and a small neighboring vein. So, I will skip this. There are some other variants which I will not go through in detail right now. Sorry about that. So, brain imaging, this is the main topic of my talk. So, why are we seeing and what are we seeing? We tried to summarize this a couple of years ago because there are very distinct imaging features of SIH on brain imaging. If possible, a brain MRI is the most adequate image because there you can depict and see most of these imaging findings. So we try to look at things like subdural hematomas. We see that there is a thickening of the dura, here in yellow color. We see that the pituitary is enlarged, so probably this is an enhanced or prominent hyperemia of the pituitary gland. We can see that there is sagging of the brain. And this is something that back in the days, in 2008, was called as the SIEPS criteria. The starting letters of all those signs. So what are we seeing there? So there are subdural effusions. So these patients have small collections, and especially you might say something in an 80 or 90-year-old, this is something that you might see, but these are people that are in their 30s and 40s. It's definitely very abnormal to see that in such a young person, and as said by Jürgen, even in elderly, you should think about something as SIH when seeing subdural hematomas. What do we see else? We see a very homogeneous enhancement. This is very homogeneous. The entire dura is enhancing. We can also see that the tentorium is enhancing. So in most generally, it's the entire dura, also infratentorial, where we see a very, very strong, very homogeneous, very smooth enhancement. In contrary, if you have just a reactive enhancement, so for example, in a CSF case, as on the right side, you can see that that is very homogeneous. As said before, it's the tentorium which is enhancing, whereas on the other hand, this is a non-SIH case where you can see a certain degree of enhancement, but it's just very localized and focal on the side of the dural collection. So this is something which might help you to distinguish a generalized hypotension versus a very localized and focal one. What do we see else? We see very rounded veins. So as I said, the blood compartment enlarges. So it's something we usually see the veins as triangular, so small triangles, or concave. Here in these cases, it's very rounded shape. So this is something which is very, very typical, especially in the early stage of the disease. What else? We see that the pituitary becomes very large. The size of the pituitary can vary according to sex and age, but it's definitely not normal to have a pituitary which is 7, 8, 9 millimeters, especially in a male, maybe in his 50s or 60s. This might be normal in a woman giving birth to a child, but this is a way of an enlarged pituitary. And in addition, what we can see, that there is contact between the optic chiasm and the pituitary gland, something we don't usually see in normal subjects. What else? We can see that there is a very slumped midbrain. You can see that all the midbrain is being basically sucked down. You can see that, again, the pituitary is very large. We have a tonsillar herniation. The tonsils are way below the foramen magnum, and everything is just being pulled down. You can clearly see that. And also the shape of the pons and mesencephalon, they are basically falling down. So this is something in very severe cases which also might result in GCS, decreased GCS. Something that has been mentioned before, in very, very severe cases, we might see a superficial siderosis also in the supratentorial compartment, but very classical feature of long-standing SIH that has not been treated is infratentorial superficial siderosis. And something we learned more recently, in patients which have had SIH for a very, very long time, there's even bone remodeling because there is loss of CSF, so something needs to compensate. So usually in the early time window, it's the blood compartment, so the veins, the enhancement, and in the long term, even the skull is trying to compensate. And what we see then in these patients, we have this layering of bone. So this is something where the missing CSF volume is being compensated by increased bone production, and we see this layer on the inner surface of the skull. Very subtle findings that you might also, I'm going into the detail because you're imaging audience, something that is very small and tiny is, for example, this is a very small intercavernous sinus. Usually you don't see a T2 hyperintense structure below the pituitary. What is this? This is again enlargement of the veins. This is the enlargement of the intercavernous sinus. This is a very small and tiny finding, just to give you a hint that there are various findings that you might see. We tried, because there's a lot of these findings, and sometimes when you go to a congress about thrombectomy or stroke, if somebody says this is aspect 1 or aspect 10, everybody in the room who is involved in the matter knows what aspect 10 means. In brain imaging, we were saying, it looks like maybe a little bit, but what do you mean? So we try to summarize this in a score. So there are 3 signs. So there's subdural hematomas, there's the pachymeningeal enhancement, and the venous distension. And there are 3 quantitative signs. So that's the suprasellar cistern, so the distance between the pituitary gland and the optic chiasm. Then there's the prepontine cistern, measured at the midline, so here, and the mammaropontine distance. And when summarizing these, we try to devise a score, and the score goes from 0 to 9. 0 with a very low probability of an underlying CSF leak, whereas if you go to 5, 6, and so on, the probability of having a leak is very high, okay? So that was the main idea. However, people have criticized it and said that it's not a good score. But as always in medicine and with scores, you need to know how to apply it. So for example, just to demonstrate you the limitations or to demonstrate the important findings here. So we have a female patient, symptom onset in July 2025 with symptoms compatible with SIH, and the patient has a follow-up in May 2026, so almost 1 year later, and the brain MRI is normal. We don't see any brain sagging, the veins are not rounded, the distances here are very much normal. So we have a normal brain MRI. We do a spine MRI, so we are at 0 basically here. We do a spine MRI, and there is a clear leak. So how is that possible? If somebody with a leak has a brain MRI score of 0, well, we try to look at the images from back then. And if we pull up the images from July 2025, 1 year before, it was clearly very, very abnormal. and it demonstrates a full-blown picture of SIH. Subdurals, we see those rounded veins here, we see dural enhancement. If we look at a different slice, we can see very rounded sinuses. This is not the normal shape of the superior sagittal sinus, and we can see this huge pituitary. So this would be a score of 8 or 9, so the full-blown picture. So how is that possible? We try to look at it with almost 200 patients, and what we can see, if you look at this graph, on the x-axis we have the time since symptom duration. So the disease starts and then it progresses. In the beginning, you can see there's actually an increase. This is the score or the odds ratio of the score being higher than 6. But let's say it's the score. So in the beginning, when the patient comes within the first 4 weeks, you will see a clearly abnormal image around a SIH score of 6 or 7. It peaks around week 5 to 7. So if you see the patients in the very, very first few weeks, the MRI will be abnormal, or the probability of the MRI being very suspicious looking is very high. If, however, your patient is being referred to you by your colleagues, maybe almost 1 year later, the MRI will have normalized by then. So this is extremely important to keep that in mind, that just based on a brain MRI, you cannot exclude SIH because it will normalize. And if we try to look at 3 groups, so if you see patients within first 10 weeks, so 90% will have a high score, so they will be a very abnormal looking brain MRI. And only a very, very small proportion of patients with a leak will have a normal brain MRI. However, if you see patients after 1 year, almost half of them will have a low or intermediate score. So then you need to keep this in mind and not exclude the patient because he presents late. We try to look at if there are other factors that might have an influence on the SIH score. So the symptom onset clearly has an influence. The leak level, so if the leak is in the upper thoracic spine or even in the lumbar spine, does not really have an influence. So we can see that the score is very, very stable. Cervical spine leaks are very rare. So for most leaks, thoracic, which is the highest number of patients, the score at presentation is almost the same. If you look at the leak type, so leak 1, type 1, type 2, CSF venous fistula, it also does not have such an important influence. So it's important to keep in mind, brain MRI, symptom duration, those 2 things are things to keep in mind. Why is that? Why is the brain MRI normalizing? You could suggest that maybe it's an increase of CSF production, but we don't have any data for that. I don't want to go into detail, but there is no clear evidence to support that as CSF is leaking, we have an increased CSF production. So that is not working. So do we lose less CSF as the disease progresses? And well, we know already that a brain MRI can normalize after treatment, so that works. But can it also happen spontaneously? Yes, we know that after treatment, so if you have a skilled surgeon like Jürgen, and there is a leak, you close the leak, what happens? If you look at the baseline score, the patients at presentation, it's around 6, just as in our cohort. You close the leak surgically, the brain MRI score normalizes to 1.4. So it normalizes because it's being sealed. What is happening spontaneously? Spontaneously, in the early time window, what we can see on spine MRI, that the fluid is going everywhere. On spine MRI, we can see that CSF is oozing in every foramen. It's very unorganized. In late stage of the disease, so when the patients come after 1 year, we can see that those are a lot more oval shaped. So the epidural collections are very rounded, suggesting that probably the spine and our body is trying to cope with it, and is trying to seal off, to close it. However, doesn't succeed to completely close it off, but partially, which helps to improve the score. The brain MRI becomes more normal, but still the CSF leak is not closed. So coming to an end, SIH is a lot more than just a headache. There can be various symptoms that are associated with it. Just keep in mind, for example, the audiovestibular symptoms and the connection between CSF and the perilymph. There are different pathologies. We will always go through it because it has great importance for brain imaging, but also especially for spine imaging. Something to potentially use is the brain score, because it gives you a quantifiable measure how abnormal brain imaging is after treatment if brain imaging has normalized. So this is something to keep in mind and use it. And it's very important to keep in mind that brain imaging is not constant. It may change, and it may change in the according to the stage of disease. It might become normal in the later stage of disease, and it's very important to know how long the patients have been symptomatic or when it started in order to really interpret this. So thank you very much. There are some things we try to organize. I think Jürgen already mentioned the most important thing. And thank you very much for all the colleagues which are involved in this. Just a few here from Freiburg, and Lalani Carlton-Jones from the UK, which I'm very grateful for knowing them. Thank you very much.